Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/xzg. This activity is supported by an educational grant from Apellis Pharmaceuticals.
Welcome. I'm Vinita Kumar from the University of Alabama at Birmingham in the U.S. And today we're doing exactly what nephrology education should be, getting into the weeds on real patients, real decisions, and a new era of treatment for two of the most challenging glomerular diseases we face, C3 glomerulopathy and IC-MPGN. So let's jump right in on the first case of C3GN. And I want you to sit on this case and look at this and not jump into conclusions right away. This is a 17-year-old with biopsy-proven C3G, 18 months of supportive care. She's on RAS blockade, blood pressure management, and her protein creatinine ratio has climbed from 1.2 to 2.8 grams per gram. Her complement level C3 is persistently low, but her eGFR is still holding. The kidney has yet not declared defeat, but the alarm bells are ringing. And the critical framing here is eGFR stability can be falsely reassuring. Proteinuria is the canary in this coal mine, and we have a number of questions we want to answer as outlined in that second box, starting with our first question, is she at risk for progression? So let's jump right in and answer that question. Is she at risk for progression? Short answer, yes. Emphatic answer, absolutely yes. Close to half of pediatric C3G patients progress to kidney failure within a decade of diagnosis. She has not one, but several high-risk signals stacked against her. Proteinuria that has more than doubled, persistently low C3 pointing to ongoing complement dysregulation, and 18 months of non-response to supportive measures. In C3G patients, waiting for eGFR to fall before acting is like waiting for the house to be on fire before buying a smoke detector. We want to intervene before that decline, and that window is right now. Again, rising proteinuria and C3GN is the strongest predictor of progression. Do not anchor decisions on a stable eGFR. So what are our tools? What are our treatment options? Here's the answer. Until recently, complement inhibition in C3G was off-label territory. Enter Valiant. That changed in 2025. Pegcetacoplan, a C3/C3b inhibitor, became the first FDA-approved complement inhibitor for adolescents aged 12 and older. The evidence comes from the Valiant Phase 3 trial that was an international double-blinded randomized placebo-controlled trial, the full methodologic landscape that enrolled 55 adolescents aged 12 to 17 and included C3G patients, both native and post-transplant. And if you then look for the efficacy data in the next slide and look at the adolescent subgroup specifically, the primary endpoint was a clinically significant 74.5% reduction in proteinuria, actually slightly better than the overall trial population at 68.1%. As a secondary endpoint, 71% of treated adolescents achieved at least 50% proteinuria reduction. These numbers are not subtle. This is not a drug that's nudging the curve. It's resetting it. And then what is even more interesting is in that next slide where it shows you that the response is a sustained response. It's not a flash in the pan. Proteinuria reduction was apparent by week 4 and sustained through week 26. The trajectory mirrors the adult population. What we're seeing is that the response was early, rapid, durable, and this consistency matters enormously when you're counseling a teenager and her family about starting a lifelong therapy. So, here is a challenge question for you. As this adolescent case unfolds, the central question becomes not only whether supportive care is still enough, but how to recognize the moment when disease activity warrants a more targeted approach. This next episode then builds on this decision point, examining how clinical, biochemical, and practical considerations come together when discussing escalating therapy with patients and families. So stay tuned for this next episode. All right, so now let's jump in and talk about the safety overview. So efficacy earns the headline, but safety earns trust. So in this adolescent cohort, the safety profile was consistent with the overall trial population. No new signals. Treatment emergent adverse events were manageable and largely non-serious. That said, there is one domain that demands serious attention, and it's not optional. So when you look at this next slide, you see that pegcetacoplan works by inhibiting C3 broadly, and C3 central to opsonization and clearance of encapsulated bacteria. That means meningococcus, pneumococcus, and Haemophilus influenza. The risk is real, and it's why pegcetacoplan is only available through a restricted REMS program. Providers must enroll. Full stop. This is not a medication you prescribe and hand off to the community pharmacist. The REMS enrollment is mandatory before prescribing. Build that into your workforce practice before you need it urgently. In teenagers, the infection risk context is particularly acute. Why? They're in school, social settings, crowded environments, and compliance with the twice-weekly subcutaneous infusion in a real world, that's challenging. Mitigation then requires proactive vaccination. Meningococcal vaccine that covers all the serogroups, A, C, W, and Y, as well as the serogroup B. That's why there are two separate ones outlined here, or there could be a combination one. Also vaccinations for pneumococcal, as well as Haemophilus influenza type B. All of these need to be completed at least 2 weeks before starting treatment. Now, if urgent treatment is needed before vaccinations are in place because we simply didn't anticipate patients needing this urgently, then antibiotic prophylaxis bridge needs to be in place to bridge that gap. And there is a huge information package available for that you can review that has various combinations starting with Cipro and converting to penicillin V, and you can refer to your local pharmacy log on that. Let's get to the next part. Monitoring is equally rigorous. Watch for fever, stiffness, confusion, rash, respiratory symptoms. You have a list of these already outlined, but the key learning points are vaccination first, then treat. If situation is urgent, prophylactic antibiotics. As outlined, there are a number of things to monitor. Response to therapy markers, both clinical and complement biomarkers. Watch out for the infusion-related side effects that are outlined there. But I want to spend a little bit of time on this next part, which is counseling adolescents and families. The clinical checklist for counseling covers infection risk, vaccine protocol, treatment duration, which is twice weekly and likely lifelong, and managing realistic expectations and what response looks like. The most common adverse events are infusion site reactions that were in the previous slide, as well as fever and nasopharyngitis, influenza, cough, nausea, and fatigue. None of these are trivial for a teenager. They affect school, sports, social life, so acknowledge that. Then pair with it the alternative, which is untreated progression, leads towards dialysis. So, the key takeaway and transition for this adolescent is she has active progressive C3 unresponsive to supportive care. She meets eligibility criteria for the first and only FDA-approved complement inhibitor in her age group. The risk-benefit calculation, when supported by Valiant data, now favors treatment. The infrastructure to do that is safely already in place. We need to use it. So here's your challenge question. Please stay tuned for the next episode. All right, we are going to look at this next case of a 42-year-old with immune complex MPGN. So she has been on 9 months of mycophenolate mofetil and prednisone, and the proteinuria is stubbornly sitting at 1.3 grams per day. No meaningful improvement. Her C3 remains low, and she wants off the prednisone. She has weight gain, mood changes, and she's telling us in plain terms the current plan is failing her on multiple levels. She undergoes a repeat biopsy, and the ongoing subendothelial deposits confirm what the labs were already suggesting: active disease, uncontrolled disease. So let's be precise about what failure means in this context. Non-response to 9 months of mycophenolate mofetil and prednisone with ongoing low C3 levels and persistent proteinuria is not a plateau. It's a signal. The complement dysregulation is not being addressed by the immunosuppression. The subendothelial deposits confirm ongoing injury. And the question isn't whether to change course. The question is what to change it to. So, what do we change it to? If it's not immunosuppression, where do we go next? At this point, the evidence seems to point towards complement inhibition. Alternative immunosuppressive approaches, if not prednisone or mycophenolate mofetil, could be rituximab, basiliximab, cyclophosphamide, even eculizumab. And those therapies have been tried. They exist, but they carry inconsistent evidence in IC-MPGN. Anecdotal data exists inconsistently again. Genetic testing for complement pathway dysregulation is increasingly relevant, and it can support the case for targeted therapy. We've seen evidence for that. There is now an approved option, pegcetacoplan, a C3/C3b inhibitor again, same drug, same mechanism, now validated in adult IC-MPGN through Valiant. So then let's look at the efficacy data. The Valiant primary endpoint for the overall adult population, a 68.1% relative reduction in urine protein to creatinine ratio versus placebo at week 26. So 60% of patients in the treatment arm achieved at least 50% proteinuria reduction as a secondary endpoint. So for a patient who has seen essentially no improvement in 9 months on 2 immunosuppressants, these are meaningful numbers, not incremental, transformative. The urine protein creatinine endpoint is log transformed, which appropriately handles the wide variance in baseline proteinuria. I always say don't let the statistical framing obscure the clinical magnitude. This is pretty impressive. So, what's the safety profile? The adult safety profile mirrors the adolescent data, manageable adverse events, no new surprises. The REMS obligation applies equally here. Hey, biology doesn't change just because the patient is older. So, here is a challenge question for you. So what did we learn? When immunosuppression fails to deliver meaningful clinical improvement in IC-MPGN, the care team must reassess both the biology of the disease and the burden of ongoing treatment. The next episode then explores how to translate evidence of non-response into a confident, patient-centered decision about switching therapy. All right, so the adult REMS framework follows the same architecture as the pediatric version we just visited in the previous episode. However, I would love to point out some very important nuances. And reminder again that providers should try and proactively become part of the REMS so that it's built into your workflow and you're not waiting for events to happen to scramble at the last minute. What are these important nuances then? Upper respiratory tract infections are a particular concern compared to the adolescents. Therefore, monitoring for infection must be systematic. Look for fevers, chills, headaches, stiff neck, rash, confusion, dyspnea. Any of these should trigger immediate evaluation. Again, serious encapsulated bacterial infections can be fatal if treatment is delayed. So, providers, please enroll. Vaccination must precede therapy. Same reminder, proceed by at least 2 weeks and cover the gap with antibiotics. Another important reminder, patients must carry the safety card for 2 months after discontinuation. I do want to remind you that consider interrupting pegcetacoplan in serious infection is in the label for a reason. This is not hypothetical. All right. How do we counsel our adults compared to our adolescents? For a 42-year-old patient, the counseling conversation has a particular texture. She's already been burned by steroid side effects, physical and psychological. She needs to understand that complement inhibition is a different modality, a different risk profile, and a different expectation-setting exercise. Twice weekly subcutaneous infusions, likely lifelong, vaccination upfront and maintained, infection vigilance always. These are not small asks, but these come with evidence behind them. Therefore, shared decision-making requires honesty about treatment burden. Lifelong weekly infusions is a commitment. Acknowledge it, then let the data speak for itself. What should the long-term management then look like? Well, there are currently no long-term data on complement inhibitors in IC-MPGN. We're building the evidence in real time. What we do not know is that treatment holidays are strongly discouraged. Uncontrolled complement activation in IC-MPGN can cause progressive irreversible kidney injury. The risk of stopping is not theoretical. The working framework: treat continuously, monitor closely, stay tuned for long-term data that phase 3 follow-up studies will generate. So what is our key takeaway? For this patient, 9 months of failed immunosuppression, persistent complement dysregulation, and ongoing biopsy evidence of active disease. Pegcetacoplan is FDA approved for IC-MPGN, and the Valiant data support its use here. The challenge is not whether she's eligible, it's executing the transition safely and with her full understanding and buy-in. So here is a challenge question for you. Please stay tuned for the next episode. And now for our last and final case of recurrent C3GN post-kidney transplantation. So this is a 36-year-old that had a kidney transplant 3 years ago. And this was at a time when no targeted complement therapy was available. Now, 3 years later, they have new onset proteinuria, 1.8 grams per gram, along with declining eGFR. And on biopsy of this new kidney has evidence of recurrent C3GN with C3 dominant deposits. And here's the practical complexity. His care is split between the transplant center and the community nephrologist, who is appropriately uncertain about initiating a newly approved complement inhibitor in the context of a patient who's already on maintenance immunosuppression and has a complex transplant history. So this case is more than about pharmacology. It's about care coordination. It's about communication between centers, building confidence at the community level to implement specialist-initiated therapy. So let's talk about recurrence risk post-transplant. C3GN is a systemic complement disorder. The kidney doesn't generate the disorder, at least not that we know. It's a bystander. Transplanting a new kidney doesn't fix the complement dysregulation. It just gives the disease a fresh organ to work on. And histologic recurrence has been reported anywhere from 60 to 90% of cases across case series. It's been reported to occur as early as 13 days post-transplant. And early presentation is often subclinical. Rise in protein, hematuria, low C3 levels, Those all happen later, and then overt graft dysfunction happens even further down the line. And so surveillance post-transplant and C3GN in patients is something that we need to be thinking about. So standard of care for these patients has been really, up until now, intensification of immunosuppression. Baseline immunosuppression has been mycophenolate increase in that dose, or prednisone, and sometimes off-label use of anti-C5 agents like eculizumab or ravulizumab. And as we all know, results have been inconsistent. Now there is more. Both pegcetacoplan and iptacopan have data in transplant recipients. Pegcetacoplan through the Valiant phase 3 trial and iptacopan through the phase 2 study. This is new territory, and the data are encouraging. So let's review the specific efficacy and safety data. In Valiant, pegcetacoplan was evaluated as an add-on to stable standard of care in transplant recipients with non-rapidly progressing disease. The primary endpoint, a 65% proteinuria reduction against closely tracking the overall trial population at 68.1%. The consistency across subgroups is one of the more reassuring features of Valiant. It doesn't appear that transplant status meaningfully attenuated this efficacy. The secondary endpoints from the transplant subgroup, they demonstrated sustained benefit across proteinuria and kidney function measures. The full data are on your slide, but the pattern is consistent. Early reduction, sustained response, no unexpected divergence from the broader trial. As far as the morphologic endpoint, all 4 patients after treatment with pegcetacoplan were found to have no C3 staining compared to baseline biopsies. And the safety data was pretty reassuring too. No deaths, no rejection episodes, no graft loss. So in a population on maintenance immunosuppression, this is a meaningful statement. The adverse event profile was consistent with the broader Valiant cohort. So the transplant settings adds an infectious risk layer, and these patients are already immunocompromised. REMS discipline is even more critical here than in native kidney disease. So here is a challenge question for you. And here's something that we all learn as a good take-home point. Recurrent C3G after transplant adds another layer of complexity, requiring clinicians to balance emerging treatment options with immunosuppression, safety, and care coordination. The next episode now will focus on how multidisciplinary teams can support timely initiation, continuity of care, and shared decision-making in this high-risk setting. Thank you. All right, so we've talked about REMS counseling in both the previous episodes, and we are going to talk about it again because transplant recipients face a compounded infection risk. Why? Again, they have baseline immunosuppression plus complement inhibition-mediated suppression of bacterial opsonization. So the encapsulated organism risk is amplified. Everything in the standard REMS framework applies, plus vigilance for opportunistic and viral infections driven by concomitant immunosuppression. Monitoring must track both graft function and systemic infection markers. If infection is suspected, evaluate immediately and consider interrupting pegcetacoplan. Allograft-specific monitoring, including evaluation for rejection per transplant center protocol, must run in parallel with the complement inhibitor monitoring framework. We also need to be counseling our post-transplant patients, counseling them about recurrence and a new therapy carries psychological weight. The recurrence itself is a blow. Gosh, they were planning a whole new life, thinking their native disease was at bay, and now it comes back in the transplant kidney. That is a huge thing to contend with. The prospect of another complex, lifelong treatment on top of that is another added layer. So acknowledge this emotional dimension, work with them, support it, then reframe it. For the first time, that's the reframe. For the first time, there is an evidence-based, FDA-approved tool specifically validated in patients like him. The question is not whether to try it, it's how to do it right, how to use it and use it in the correct way. And that's where care coordination comes into place. What does that mean? This is where system thinking matters as much as the pharmacology. Effective management of recurrent C3GN in transplant recipients requires active coordination between the tertiary transplant center and community nephrologists. This means creating protocols that are shared protocols, clear communication channels, explicit agreement on who monitors what. What is the responsibility of the transplant center? What's the responsibility of the community nephrologist? Who is going to do what? How are they going to communicate the information? How are they going to keep track of this information and share it back and forth? The ongoing phase 3 studies are going to be incredibly important. They are including transplant populations, and this will add long-term data. And in the meantime, the evidence we have supports initiating therapy. So let's not let care fragmentation be the reason treatment is delayed. Building the coordination infrastructure before the patient needs it is the best way to support them. Waiting until recurrence to figure out the referral pathway is a little too late. Let's put that pathway in place beforehand. So what's our final takeaway here? For this patient, recurrent C3GN post-transplantation is a high-stakes clinical situation. The evidence base now supports complement inhibition, especially when associated with graft dysfunction, decline in GFR, proteinuria. Safety demands REMS enrollment, vaccination, infection vigilance, and close coordination between transplant and nephrology teams. And psychological support for the patient is not really optional. So here is a challenge question for you. I hope this educational session was insightful. Thank you so much for watching and joining us on this journey.
This has been an activity published by Peer Voice.